Acute pyogenic bacterial meningitis is a critical and rapidly progressing infection of the meninges, the protective membranes surrounding the brain and spinal cord, caused by the invasion of bacteria into the central nervous system, CNS. This condition can result from direct bacterial entry through the bloodstream, hematogenous spread, contiguous spread from adjacent structures such as the sinuses or ears, or from traumatic injury to the skull or spine. The most common pathogens responsible for this infection are Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenza, although other bacteria including Listeria monocytogenes and Group B Streptococcus may be implicated depending on the patient's age or immune status. Pathophysiology. The bacteria typically invade the bloodstream, causing bacteremia, and then cross the blood-brain barrier, leading to inflammation of the meninges. The inflammatory response results in an increased permeability of the blood-brain barrier, leading to an influx of immune cells and proteins into the cerebrospinal fluid (CSF), which increases intracranial pressure. This process can cause cerebral edema, reduced blood flow, and ischemia, contributing to potential neurological damage. The infection can also trigger a systemic inflammatory response, leading to septic shock, organ dysfunction, and even death if not promptly treated. Epidemiology and risk factors of acute pyogenic bacterial meningitis. Acute pyogenic bacterial meningitis is a life-threatening infection that affects all age groups, but the incidence varies. It is most common in neonates, infants, elderly, and immunocompromised individuals. Age. Neonates are at highest risk due to an immature immune system, with pathogens like Group B Streptococcus and E. coli being common. Young children and adolescents are more prone to Neisseria meningitidis and Streptococcus pneumoniae infections. The elderly have increased risk due to age-related immune decline and other health conditions. Immune status. Immunocompromised individuals, including those with HIV, cancer, or organ transplants, are at higher risk for bacterial meningitis. Asplenia, absence of a spleen, also increases susceptibility, particularly to Streptococcus pneumoniae and Neisseria meningitidis. Underlying conditions. Chronic diseases like diabetes and alcoholism, head/neck infections, trauma, and surgical procedures involving the brain increase the risk. Crowded environments, e.g., dorms, military camps, facilitate the spread of Neisseria meningitidis. Prevention includes vaccination, e.g., for Neisseria meningitidis and Streptococcus pneumoniae, and prophylactic antibiotics for close contacts of infected individuals. Pathogenesis and causative organisms of acute pyogenic bacterial meningitis. Acute pyogenic bacterial meningitis occurs when bacteria invade the central nervous system, CNS, leading to inflammation of the meninges. The pathogenesis involves several stages, starting with bacterial entry and ending with an inflammatory response that damages brain tissues. Entry route. Bacteria typically enter the CNS through hematogenous spread from the bloodstream, where bacteria travel from distant sites of infection. Direct extension from adjacent structures like the sinuses or middle ear. Traumatic injury or neurosurgery, which introduces bacteria directly into the meninges. Blood-brain barrier, BBB. Once bacteria enter the bloodstream, they cross the blood-brain barrier, BBB, a protective membrane around the brain. The bacteria disrupt the barrier's integrity, allowing immune cells and inflammatory mediators to enter the CNS. This results in inflammation, increased pressure, and potential neurological damage. Causative organisms. The most common causative bacteria include Streptococcus pneumoniae, most common in adults and elderly. Neisseria meningitidis, common in adolescents and young adults. Haemophilus influenza type B (HIB), common in children but less so due to vaccination. Listeria monocytogenes, affects neonates, elderly, and immunocompromised individuals. Group B Streptococcus, leading cause in neonates. Each of these organisms has unique mechanisms for crossing the blood-brain barrier and initiating infection, leading to severe inflammation and potential neurological complications. Clinical presentation of acute pyogenic bacterial meningitis. The symptoms of acute pyogenic bacterial meningitis develop rapidly, often within hours, and typically include fever. A high fever is a hallmark sign of infection. Headache, Severe persistent headache is common, often described as one of the worst headaches ever experienced. Stiff neck. This is a key symptom, caused by inflammation of the meninges, leading to difficulty in bending the neck forward. Other symptoms may include nausea and vomiting, due to increased intracranial pressure, photophobia, sensitivity to light, altered mental status, confusion, drowsiness, or even coma in severe cases. Seizures can occur due to brain irritation. Skin rash. In cases of Neisseria meningitidis infection, a petechial or purpuric rash may appear. In neonates and young infants, signs may be more subtle and can include poor feeding, lethargy, bulging fontanelle, and high-pitched crying. The rapid onset of these symptoms requires immediate medical attention for diagnosis and treatment to prevent severe complications, including brain damage or death. Diagnostic workup for acute pyogenic bacterial meningitis. Lumbar puncture. LP, the primary method to obtain cerebrospinal fluid (CSF) for analysis. CSF analysis. O appearance, cloudy or turbid. O cell count, high white blood cells, mostly neutrophils. O protein, elevated. O glucose, low. O gram stain and culture. Identify the causative bacteria. Blood tests. O CBC, elevated white blood cell count. O blood cultures. Identify bacteria in the bloodstream. O CRP/procalcitonin, elevated in bacterial infections. This workup confirms the diagnosis and helps guide treatment. Imaging findings for acute pyogenic bacterial meningitis. CT scan. O primarily used to rule out other conditions, e.g. brain abscess, stroke, before performing a lumbar puncture. O may show signs of cerebral edema, increased intracranial pressure, or ventricular enlargement in severe cases. MRI. O provides detailed images of the brain and meninges. O can show inflammation of the meninges, brain swelling, or brain abscess. O preferred if there are complications like septic thrombophlebitis or focal neurological deficits. Imaging is often supplementary to the lumbar puncture and CSF analysis for confirming the diagnosis. Differential diagnosis of acute pyogenic bacterial meningitis. Viral meningitis. Similar symptoms but milder. CSF shows fewer white blood cells, normal glucose and lower protein. Encephalitis. Brain inflammation, often viral. Includes altered mental status and seizures, which are rare in bacterial meningitis. Subarachnoid hemorrhage. Each severe headache with a history of trauma. CT/MRI shows blood in the subarachnoid space. Brain tumor, headache and neurological symptoms. Imaging reveals a mass effect, and CSF is typically normal unless infection is present. Differentiation relies on clinical signs, CSF analysis and imaging. Treatment principles for acute pyogenic bacterial meningitis. Antibiotics. O empiric therapy with broad-spectrum antibiotics, e.g. ceftriaxone or cefotaxime, and vancomycin to cover common pathogens. O once the causative organism is identified, treatment is adjusted based on specific antibiotic susceptibility. Supportive care. O includes fluid management, pain control, fever management, and monitoring for complications, e.g. seizures, intracranial pressure. O patients may require intensive care in severe cases. Steroids. O dexamethasone may be given, particularly for Streptococcus pneumoniae infections, to reduce inflammation and improve outcomes if administered early, usually before or with the first dose of antibiotics. Early, aggressive treatment is essential to reduce mortality and prevent long-term neurological damage. Prevention and vaccination for acute pyogenic bacterial meningitis. Vaccination. O meningococcal vaccine. Protects against Neisseria meningitidis, especially in adolescents and those in crowded settings. O pneumococcal vaccine. Protects against Streptococcus pneumoniae, recommended for young children, the elderly and immunocompromised individuals. O HIV vaccine. Protects against Haemophilus influenza type B, a leading cause of meningitis in children. O listeria vaccines are not available, but prevention involves proper food safety for high-risk individuals. Preventive measures. O antibiotic prophylaxis. For close contacts of individuals with meningococcal meningitis. O good hygiene. Handwashing and respiratory hygiene to reduce the spread of bacteria. vaccination and early prophylactic treatment help reduce the risk of bacterial meningitis. Medicam is a specialized channel dedicated to medical students, focusing on the fundamentals of pathology and its allied branches. This lecture has been meticulously prepared and designed by Ghulam Farooque. If you require a PowerPoint version of this lecture, simply leave a comment, and we will provide the file at the earliest convenience. We encourage you to share this lecture with undergraduate and postgraduate students to support and enhance their learning in pathology.